Good morning, everybody, and thank you for inviting me here. I'm Giulia Amore. I'm a neurologist and a PhD student from Bologna, and today I'm going to talk to you a little bit about a study I've been conducted between Italy and Los Angeles during my residency about Leber's hereditary optic neuropathy in women. I'll try to address some of the questions that are still open regarding this disease in women, such as why are women less affected than men? If women have a different age at onset or the disease itself is different in women compared with men, and what's the real penetrance of LHON in women, meaning what's the real proportion of women getting affected among all LHON mutation carriers. So in order to do this study, you should imagine it divided into three parts. So in the first part, we looked at some factors that are known from literature for being protective or risk factors, in particular toxics, hormones, and other diseases. So we built a specific questionnaire and administered it to a group of affected females and compared the results with a group of unaffected females carrying the mutations. In the second part of the study, we looked at gender differences, so differences between females and males, in particular age at onset and the clinical manifestations. In the third and last part, we revised a large number of LHON families and calculate again the penetrance, so the number of affected, and compared it between females and males. So let's start with some results. In the first part, we compared 39 affected females with 111 unaffected females. We asked about toxic exposures, and we found that in the affected group, there was tendency in higher use of alcohol and definitely a significantly higher use and duration of smoke habit. So this once again stress the fact that smoke in particular is a known and confirmed risk factor for developing the disease and should be absolutely avoided. Regarding hormonal factors, we know from literature that estrogens, which are the female hormones, may have a protective role. So we asked our women about pregnancies, hormonal replacement therapies, and menopause age. We found that in the unaffected group, there was a higher number of pregnancies. This result is a little bit difficult to interpret because we don't know if the pregnancy, which is a time with high levels of hormones, can have a protective role in the life of a female with a LHON mutation, or if this result is just due to the fact that unaffected females can lead a more regular life. In the same way, we found in the unaffected group a tendency, so not significant, higher use of hormonal replacement therapies. So this aspect is something that should really be more investigated in the future, because if confirmed that hormones can have a protective role, we could think about some strategy to prevent maybe the disease in women. Regarding the menopause, so the time when hormones level drop, we were expecting earlier age at menopause in the affected group, which we did not found. But looking more closely just at the affected females, we found that a significant proportion, 20%, develop the disease after the menopause. So this period in the life of a woman with LHON mutation should be really monitored closely, because there's some even low probability of getting affected. For what concerns other comorbidities, so other diseases, we found that a significant proportion of affected females had also multiple sclerosis, so 10%, which is higher than the prevalence of multiple sclerosis in general population, where it's about 0.1%. So the association of multiple sclerosis and LHON is already known. It's called Harding disease. What is not clear yet is if it's just a chance occurrence of two diseases in the same person, or more probably there's some kind of interaction between the two diseases. Regarding other autoimmune diseases, we found a slightly higher prevalence of endocrinopathies, in particular thyroid disease, in all women, both affected and unaffected, which was 22%, a little bit higher compared with the 15 in general population, even if not significant. So again, more studies are needed to see if there's some association among this kind of autoimmune disease and LHON disease. What was really interesting was the prevalence of migraine reported by both the affected and the unaffected group, which was over 50%, definitely higher than the rate in general population, around 18% in women. So we know that there is evidence of mitochondrial abnormalities in the migraineurs' brain, but we should discuss if migraine itself should be considered a manifestation of the LHON, of being a carrier of LHON mutation, even without the visual defect. Okay, let's move now to the second part of the study regarding the gender differences. So we compared the age at onset of 93 affected females and 197 males. And we found that women have a significantly older age at onset, so 27 years, compared with 22 years in males. And also that women have a different distribution in age at onset. Since while in males we can distinct a clear peak around 20 years of age, which is the classical type, and a second peak around 40 years of age, which is due to the cases developing after toxic exposures. In women, we can distinct a third peak after 50 years of age, which can maybe be due to the cases developing the disease after menopause. For what concerns the ophthalmological manifestations, we found no significant difference between women and men in terms of visual acuity, visual fields, and OCT parameters, except for a slightly worse visual acuity in the first 5 years of disease in women. So it seems that women, if and when they get affected, can have a worse vision at the onset, but then the visual acuity, the final visual acuity and the visual outcome is the same as men. Let's go now to the last part of my presentation regarding the PENETRANCE. So I revised a total of 127 families for a total of over 2,000 carriers. And we counted 380 affected. So we get general penetrance of 14%, which is in line with the data from literature. And we also confirmed the distribution of the three mutation, with 11778 being the most common. After stratification by gender, we found that among all women, 8% were affected, while among all men, 20% were affected. So we got a female to male ratio of 1 to 2.5, which is lower than what expected from literature. So we definitely had more female affected than expected, and this is something that should be considered and known by both clinicians and patients. That was my last slide. I'd like to thank a lot my Italian group and the American group I've been working with. And a special thank you goes to the Patients Association, both the Italian and the American, who helped me a lot collecting the data. I'm really sorry for not being able to participate to the discussion after because of the time difference, but I would be really happy to answer any of your questions by email. Thank you again very much.